Good afternoon to everyone joining us for our second Experts on Air webinar series. My name is Caroline Brown from Hamilton Medical, and I'm delighted to be back today with two experts to talk about a pragmatic approach to esophageal pressure measurement. I'd like to extend a very warm welcome to Professor Francesco Moioli from Pavia in Italy, and a very familiar face in these webinars, Dr. Tommaso Mauri from Milan in Italy. Today, they're going to talk about how they manage the catheter and measurements. For those of you not familiar with Experts on Air, your cameras and microphones are switched off, but you can put all your questions directly to the experts using the Q&A function. The session is being recorded, and you'll receive a link to the recording in an email a few days after the event. For those of you who did join our high flow oxygen therapy series, please note that these webinars will be slightly longer, around 45 minutes, as opposed to just 30 minutes. So we hope that you'll stay with us till the very end. And now I'd like to hand over to our interviewer for today, Tommaso Mauri. Thanks, Tommaso.
Thanks, Caroline. Welcome to everybody. Thanks to Hamilton for organizing this. We will speak in two parts of esophageal pressure. Esophageal pressure is getting more and more known, but we are still far from daily clinical use. So we want to know to break the ice with Francesco. We decided to put up a poll that you will see in a second. So the poll asks you, do you use esophageal pressure in your daily clinical practice? So the answer are never. So you are here because you want to learn and start from zero. Rarely, like most severe patient, like 2 per month. And regularly means like you perform measures every day. I can say regularly for myself. Francesco, what would you answer?
I would say something in between in the most severe patient and regularly.
Would you say that in your unit you have always a patient with esophageal pressure? Huh?
Yes, but we have 30 ICU beds.
Yeah, but I'm saying there is always a patient with esophageal pressure.
Yeah.
Okay, so 48 people answered. Let's see the results. So the results are never is 35%. So there is a third, you have to keep in mind, Francesco, for your presentation, that never used or uses esophageal pressure, nearly half rarely, and 17% regularly. So you have also 20% of expert, Francesco. And then we have another poll that we would like to ask you if you can tell us what are the main barriers. What are you interested in the most in these two talks that we are starting? So positioning, you feel it's difficult, like how to position, where, the right filling volume, the calibration, interpreting the measurements. So you know how to calibrate, you are perfect, but then you have these transpulmonary pressures everywhere and you don't know how to use them. The need for a dedicated monitoring, you can select more than one barrier. So need for dedicated monitoring means that sometimes we use the hemodynamics if you don't have fancy new ventilators by Hamilton, and the cost, because if you need a dedicated catheter, then that will cost around I don't know, 100 euros, 120 euros in our unit, plus the monitor, etc. So people are answering, around 40 people answered. So let's see, there is a tie, not really one single answer. We can end the poll and share with everybody. Do you want to comment, Francesco?
My answer this question could be calibration and costs. So a combination of technical issue and cost. I see here that, and I'm quite surprised that only 6 indicated the need for a dedicated monitoring system. So probably this means that
most people have
in the last years that there was some spread of monitoring dedicated systems or ventilators that are now equipped with an additional port.
But I think we can say that now you will start your presentation. I think there is no particular point that you have to stress. All the one, this will always, will all be points that you will cover, and they are all important for the people following the webinar. So I think you can start your presentation, sharing your slides. There is a question and answer button that you can use from home, from wherever you are in your hospital. And if during the presentation there will be points that are not clear, you can write there and we can also interrupt. Please, Francesco, start.
Okay, thank you, Tommaso, for the introduction, and again, welcome to everybody. So this is the first part of pragmatic approach to esophageal pressure, where I will focus on this, mainly on these 5 topics. So the selection of the esophageal balloon catheter, the positioning of the catheter, the filling of the balloon, the validation test, and finally the need and the procedure of calibration of our measurement. Regarding the selection of the esophageal balloon catheter, we have 2 main options. The one on the left of the screen, so is a simple and thin catheter connected to an esophageal balloon. The advantage in this case is that is a low-cost option. The main disadvantage, in my opinion, is that is sometimes very difficult to insert in our patient. On the right, you see the other option, that is the expensive one, is a nasogastric tube equipped with 1 or 2 balloons, the esophageal and the gastric one. In this case, we have 2 main advantages. The multifunctionality, of course, and the fact that is clearly easier for us to insert in the right position in our patient, because inserting a nasogastric tube is something that we do every day in our clinical practice. About positioning, we have to know what is our target, that is the middle or last third of the intrathoracic esophagus. And my suggestion is to insert the catheter as much as possible in order to be sure that the esophageal balloon is in the gastric position. And at this point, we have to inflate the balloon. We for the positioning, we use the filling volume recommended by the manufacturer, that for our esophageal balloon catheter is 4 ml. This is the volume we use for patients under invasive mechanical ventilation, whereas in patients under non-invasive CPAP or high flow oxygen therapy, we use a lower one. At this point, where you have to withdraw the catheter step by step, looking at the pressure tracing on the screen, maybe the ventilator screen or the screen of your dedicated monitoring system. As long as the balloon is in intra-abdominal position, so below the diaphragm, you will you see a positive deflection, so an increase of the pressure coming from the balloon at each inspiration, because both during spontaneous breathing or completely passive mechanical insufflation, at each during inspiration, there is an increase of intra-abdominal pressure because the diaphragm is moving down. As soon as the balloon is at least partially in intrathoracic position, you'll see at the beginning, at the start of the patient's spontaneous effort, a negative deflection, so a drop in the pressure measured in the balloon if the patient is active, so is breathing spontaneously or is under an assisted mode of mechanical ventilation. This is not the case, of course, if your patient is completely passive. In this case, you see a positive deflection, so no difference compared to the gastric position of the balloon. So in a passive patient, we should rely on two different markers of intrathoracic position. You see in this slide. So one is the increase of the heart noise in the pressure tracing. Be aware of the fact that is an increase, is not a new, in some cases, is not a new appearance because sometimes the heart noise is already present when the balloon is in intragastric position. And then you have to see a step change of the baseline value of esophageal pressure. In most cases is a step up, increase, of esophageal pressure. In few cases, especially in patients with abdominal hypertension, can be a step down change of the baseline esophageal pressure. And finally, remember that at least in adult patient, the balloon, the distance between the nose and the balloon should be almost always in this range, 30 to 40 centimeters. And this is a case of positioning in a passive patient. So let's say the difficult case. The catheter was already inserted with a balloon at a depth of 50 centimeters. And you see, at this point, we draw by 4 centimeters, moving from 50 to 46 depth, the balloon, and nothing changed. So the same swings in the balloon pressure. So probably we are still in the gastric position. And you can also note that there is already some cardiac noise. So we have to withdraw again by other 4 centimeters the catheter. You see that as soon as you move the balloon, there is a big reaction from the patient, or let's say the esophagus. There is some swallowing. You have to wait for normalization and stabilization of the pressure. But now you see there is clearly a change, because the baseline level of balloon pressure is no more 8 centimeters of water, but is close to 15 centimeters of water. So probably we entered the thorax with the balloon. And you also can see that the heart noise is more clear now. At this point, my suggestion is to try to decrease as much as possible the heart noise, making your signal of higher quality, And you can do this by withdraw a little bit more your catheter. In this case, we moved from 42 to 40 centimeter depth, and you see that there is a further improvement. And the last small repositioning was moving from 40 to 38. This is probably more a middle esophagus than middle esophagus position than a far esophagus position. So in other words, my suggestion is to, let's say, to be a little bit hard to please when you position the catheter with the aim to have a very, very high quality signal. Because starting from high quality signals means obtain reliable measurement and respiratory mechanics and so on.
So
Okay.
Francesco, can I ask you two simple questions? So if you,
Yes.
so your suggestion is to start from far, let's say from the stomach. If you, once you're in the stomach, you need to feel the catheter already to see the tracing that you showed. You need some filling volume. What is the volume? Because you are coming now to balloon filling, but already you need some filling when you to see those tracing that you show. What is your suggestion for the initial filling, just for the positioning?
Yeah, it's this one.
Okay.
So for positioning, after you insert the catheter and you think that your balloon is in gastric position, I use the volume recommended by the manufacturer. That in my case we use a nasogastric tube equipped with a balloon with a nominal volume of 8-9 ml is 4 ml. In case of a patient spontaneously breathing with CPAP or high nasal flow oxygen, we use a smaller one, so 2 ml, for instance.
Okay. There is a question from the one of the attendees saying, is sure the catheter is in place, or she is sure the catheter is in place, but the signal is flat. So maybe, I don't know, you did a chest X-ray, you see that the catheter is there, you're sure it's in the esophagus and it's 35 to 40 centimeters, but there is flat signal. What would you suggest? Move, change the filling volume?
A very flat curve is in most cases due to a damaged balloon. So you have to check whether inflating the balloon there is an increase in the pressure, and if this level of balloon pressure is stable, because if it's slowly decreasing over time, that means that there was an injury in your balloon. And the other reason is kinking. So if the insertion was somehow difficult in your patient, sometimes there was also a kinking of the catheter, and so the transmission of pressure between the balloon and the sensor is stopped. So you have to withdraw the catheter and reinsert.
So think about something technical. Another quick question, what about the heart noise? You think that someone is asking, is it good to have large heart noise, but you are saying to minimize it? What is the correct?
Yeah, the question is good and is bad at the same time. So it's good to position, to detect the intrathoracic position of the catheter. So when you see an increase of heart noise, that clearly means that you are entering the thorax. But then to improve the quality of the signal, it's better to move from the last part of the intrathoracic esophagus that is very in touch with the heart to an upper position, so in the middle third of the esophagus, where you are still in the thorax, but the quality of the signal is higher because low or no heart noise. So all your measurement will be more reliable.
Okay, then there are more advanced questions on prone position and calibration, but I think we will arrive to that. We can go on with your presentation, I think.
Okay, thank you.
Keep in mind.
So at this point, we have to optimize the balloon filling in order to have a good quality transmission of pleural pressure to our pressure sensor. And the problem here is that the appropriate filling volume depends on the catheter we are using and the value of intrathoracic pressure of our patient. That is exactly what we want to know with our system. Anyway, this problem can be solved very easily and in a fast manner, just filling step by step our balloon, looking at the same time at the pressure tracing in the ventilator screen or in our monitoring system. So this is an example. From top to bottom, you see the airway pressure, flow, volume in green, and at the bottom you see the esophageal pressure. We started in this case with a filling volume of 0.5 milliliter, and the respiratory change of esophageal pressure was 2.5 centimeters of water. Increasing the filling volume to 1 ml, we observed an increase also of the respiratory change of esophageal pressure, so from 2.5 up to 4 centimeters of water, and a further increase of the filling volume up to 2 milliliter was able to increase the delta pass up to 7 centimeters of water. Further increase of the filling volume in this patient was not effective in improving the transmission of pressure, because you see here with 4 ml, the delta pass was again 7. And if you exceed with the filling volume, sometimes you can also see a decrease of pressure transmission, like in this case. So with 6 ml, the delta pass decreased from 7 to 5 centimeters of water. So in this specific condition and patient, the optimal filling volume was 2 ml, because this was the lowest volume associated with the largest tidal increase of esophageal pressure. At this time, you are almost ready for the validation test. I suggest just to check 2 other things. One is the shape of your esophageal pressure curve. This should be as similar as possible to the one of the volume. And if you have the possibility to select an esophageal pressure volume loop, like you see on the right of the slide, this should be aligned, so no hysteresis. And actually, the slope of this line is the compliance of the chest wall. So this is very different compared to the pressure volume tidal pressure volume loop we see normally during mechanical ventilation. And this is a video, so you can appreciate the difference between the esophageal pressure volume loop, that is the pink one, so no hysteresis at all, and the airway pressure and volume loop, where you see a large hysteresis. The reason for this difference is that the chest wall has mainly an elastic behavior, so without a resistive one. And of course, this is not the case for the airway. After this you can move to the your validation test. You have to perform, that can be done both in active and in passive patients. You have to perform an occlusion maneuver, usually attend expiration, and check whether the esophageal pressure swing and the airway pressure swing are very similar during spontaneous but occluded patient efforts, or in the active patient, of course, or during gentle chest compressions in the passive patient. The test is considered to be passed if the ratio between the esophageal pressure and the airway pressure change during the maneuver is in this range, so between 0.8 and 1.2. And this is an example in a passive patient under pressure control mechanical ventilation. This is the occlusion maneuver and the two gentle chest compression. After the maneuver, you have to check whether the two swings, the esophageal pressure and the airway pressure swing, are similar, like in this case. So here the test is passed, and when this is the case, this means that the balloon position is okay in your patient, the balloon filling volume is also okay, and your system is able to reliably transmit the respiratory changes of pleural pressure, of intrathoracic pressure. If for some reason you need absolute value of intrathoracic pressure, of pleural pressure, we need a special procedure, that is the calibration of the esophageal pressure measurement. Why? Because we are inflating.
Let's stop 1 second, because calibration is difficult. So let's make a little break.
Okay.
So one question from Anna is if there is a lot of peristalsis that makes it difficult to do, for example, this compression. Do you do anything like I don't know, increase sedation, give paralysis? No, there is, but it's not the same, correct? There is no. Do you have any tip for excessive peristalsis?
Yeah, sometimes this is a problem. You are right. In most cases, the only way is to wait, unfortunately. Consider that peristalsis, swallowing, is due to is a reaction of the esophagus, especially when to inflate the balloon to very high volumes, and when you move an inflated balloon along the esophagus. So you have to stop with the movement and wait until the end of swallowing. This can be especially a problem in small patients and more frequent in women, I have to say. But again, it was never in my experience a problem not permitting the measurements at all.
Okay. And for if you have a nasogastric tube that is in place and you want to add a small catheter esophageal pressure, do you use it even if in the presence of a nasogastric tube, or you will remove the nasogastric tube? Ian is asking.
Yeah, this is another very good question. Here we have two problems. The insertion of the esophageal balloon catheter when a nasogastric tube is already there, and the reliability of the measurement. It seems that at least there is a study suggesting this, that the reliability of the measurement when you have two two lines, the nasogastric tube and the esophageal catheter, is not that a problem. In my personal experience, could be really a problem, the insertion of the new catheter. So sometimes I have to remove the nasogastric tube and insert only the esophageal balloon catheter.
Okay, try, and then if you have problem, remove the one
Yeah.
for the time of the measure. So why you suggest the end expiration for the compression?
I didn't suggest. This is my
Yeah, your clinical practice, so you suggest.
Sorry?
It's the way you do it.
Yeah. It's
So you suggest that.
yeah. I think could be almost the same. Anyway, I think that in an active patient is probably not that different. In a passive patient, of course, if you have to add pressure when you are already at the top level, so at the end inspiratory pressure, this is of course a problem. And the other reason why, let's say, historically, the validation test is performed during an expiratory occlusion, is that you have to try to test as much as possible the same value of intrathoracic pressure that you have during mechanical ventilation.
Okay, so around 5 to 10 centimeters of water.
Yeah, in the same range, no?
In the same range.
So you are moving from PIP level towards the plateau pressure level, and not above the plateau pressure value.
So Serena is asking, delta pressure in airway pressure and esophageal pressure should be the same during the zero flow compression or inspiratory swim by the patient, correct? She's asking.
Yeah, this is correct.
0.8 to 1.2, you said?
Sorry?
0.8 to 1.2, you said?
Yeah, this is the range. So the best is when is exactly the same, 1. The ratio is 1, but it's considered to be acceptable if the ratio is in this range.
You always try to look for 1, or if you have 1.1, you go on?
I would say that if the position of the balloon is okay and you optimize the filling, is you often are able to be very close to 1.
Okay. Then how much is the filling volume for the gastric balloon? Is there a way to calibrate to know the filling is correct, or you just inflate standard?
No, for the gastric balloon, you don't need an optimization of the balloon filling, because the stomach is larger, no? It's not like the esophagus with a virtual space. So there is no reaction of the gastric wall to the inflation of the balloon. I use the volume recommended by the manufacturer. Again, is for my esophageal balloon catheter is 4 ml.
Around 4. Okay, final 2 questions, then we move to the last part of the calibration. Do you ever use a buscopan or some kind of reduce antispastic drugs for peristalsis? Did it ever happen to you that you need that?
Probably I tried sometimes, but in my clinical practice is not the rule.
You just wait.
Yeah.
And how long do you keep the catheter in place? So monitoring patients for days or just a few hours? Mila is asking.
Yeah, I would say as long as the patient needs. So of course there are again manufacturer recommendation for this, but for instance, if I remember well, the recommendation is no more than 30 days. That is a quite long. No?
I think the question is really how long you will leave it inflated. Because I mean, just the catheter is like having a nasogastric tube. You can leave. For
no
days.
problem.
But inflated for continuous monitoring for hours or minutes.
Yeah. You know, if you have if you manage manually your catheter, is not possible to have the balloon continuously inflated, because the balloon is spontaneously and slowly deflating. So this is the reason why you are, every time you approach the patient and you want to perform a new measurement, you have to reinflate the balloon.
Okay.
If you have a system, a dedicated monitoring system able to reinflate periodically the balloon, this is okay. It's not injuring the esophagus anyway.
Okay, so we have three questions left for the end. If you want to finish your presentation on calibration, please.
Yes. So I was saying that if we need the absolute value of intrathoracic pressure, we have to calibrate, because in this case, the problem is that we are inflating a balloon in the esophagus, and the reaction of the esophagus is to the increase of its cross-sectional area, is to generate some pressure. No, let's say that the inflated balloon is seen by the esophagus as a sort of bolus. In the end, we can say that the pressure that we measure inside the balloon, so what we consider the esophageal pressure, is actually the pleural pressure plus the pressure generated by the esophagus wall. Plus, if we are not able to avoid the overstretching of the balloon, the pressure generated by the balloon itself. Because the difference between a calibrated and an uncalibrated, so a direct measurement of esophageal pressure, is quite consistent. So in average 5-6 centimeters of water, but you see here that in different patients and different conditions is highly variable. This means that some calibration, some correction of this problem is mandatory. So we suggested and described a calibration procedure that is a two-step procedure. The first step is the optimization of balloon filling. We have already seen. So in this way, you are able to avoid the overstretching of the esophageal balloon, and also to optimize the transmission of the respiratory change of pleural pressure. The second step is the difficult one, is the measure of the esophageal elastance. You need to be able to remove the esophageal artifacts. That is the pressure generated by the esophagus because you are inflating a balloon inside its lumen. This second step is time-consuming and somehow cumbersome. So we can also adopt a sort of simplified procedure that takes into account the fact that you see here there is a linear increase in esophageal pressure when you inflate, increase the filling volume of your balloon. So very simply and fast, you can, at the bedside, you can just look at the volume you selected as the best volume, so the volume that is able to fully transmit the respiratory changes of pleural pressure, and remove from your measurement 1 centimeter of water for each ml of filling volume above 1. So this means that, like in this example, if you selected 5 milliliter as the best filling volume of your balloon, you can calibrate your measurement, removing from the direct measurement 4 centimeters of water. So 5 minus 1, 4 centimeters of water. And in this case, at this point, you will be able to compute the end expiratory transpulmonary pressure and the end inspiratory transpulmonary pressure as well. So this was my last slide. These are the 5 topics.
Very good.
I am ready.
A lot of questions.
And open to the last question.
Yeah. So let's start with the calibration because it's fresh. You just please repeat what are the risks of not performing this. So when we do clinical practice in the ICU, it's a hot topic now. Less is more. So we don't have to over-treat the patient, so this sometimes comes to let's do nothing and just have a coffee, but we need to calibrate, takes time, and it can be tricky sometimes. Why is it important for the physiology of the patient? I think this is the real question behind it.
Yeah, it's important because a problem of the esophageal pressure measurement is that is always overestimating the real pleural pressure. And you don't know how much is this overestimation. If you overestimate pleural pressure, you are pushed to set a very high level of PEEP or to accept very high level of plateau pressure. So there is a risk to set your mechanical ventilator and at unnecessary high PEEP level, and or potentially injurious high plateau pressure value, so too high tidal volume or no driving pressure.
Like Cesare Gregoretti is asking, for example, in robotic surgery, I think this is a relevant question. For example, in anesthesia, you have healthy patients, even if they are maybe like obese or with comorbidity, but they should go out of the operating room healthy as they came in. So really the ventilation should not add complications. So in that setting, for example, if you set PEEP based on esophageal pressure, maybe calibration is mandatory to avoid the risks.
Yeah, yes. This is a comment coming from the fact that the data suggesting that the calibration is mandatory were obtained during robotic surgery. But that was a sort of model. So it was a model of variable chest wall mechanics and variable intrathoracic pressure. So I'm not saying that we need esophageal pressure at all in patients that have healthy lungs.
Okay, so do you think that in active patient the calibration is as relevant? When you want to estimate, especially the effort, the delta pairs, the
yeah,
product,
exactly.
those are more based on delta rather than absolute values. Is this correct?
That's exactly the point. So if in your active patient,
stop sharing the screen, Francesco. Sorry, so we see your full face.
Okay. Okay, so that's the point. If your aim is to check the spontaneous activity of your patient, you don't need calibration. You just need your a good positioning and the optimization of the balloon filling to be able to fully transmit the respiratory changes.
Okay, more relevant for paralyzed, for passive, the calibration.
Yeah, but also, sometimes also in active patient, you are really interested in the stress you are applying to the lung. So if you are checking that point, I think it's better to calibrate.
Yeah, and to finish up with the calibration, does it make any difference having like a small catheter with a small filling volume or a large filling volume? Do you use any practical differences in when you do the calibration with these two catheters type?
Yeah, the surprise was that if you use a small balloon catheter, the esophageal reaction can be even greater than with a large balloon, probably because of the shape of the balloon. So what is really important is not the volume of the balloon, but how is increased the cross-sectional area of the esophagus. So the first answer is that if you use a small balloon catheter, you still need calibration. For the simplified calibration, the rule is, of course, catheter specific. So for instance, I don't know if we can use mention the manufacturer. No, okay, it's better no. Let's say that if you use that small balloon catheter with a nominal volume of 2.5 ml, the correction we have to adopt to calibrate is 3 centimeters of water for each ml of filling volume.
Okay, and then people can write you an email for specific. So let's.
I don't know all the different esophageal balloon catheters.
Let's move to the end. I have a final 2 questions. So one is the using all these technical aspects in prone position. How do you face them? Do you use it? Do you use same feeding volume, same positions, same calibration?
Yeah. Actually, the answer is that you have to reperform. So the optimization of the balloon should be retested, rechecked when something is really changed in your patient, especially position.
Okay, but the principles are exactly the same. How
Yes.
do you do the compression in prone? Just in the middle of the back?
Yeah, it's feasible.
It's feasible, very similar. Okay, and the final question, and then I think we can close here, is the contraindication. You didn't mention any contraindication. When would you stop and give up? This patient is not indicated, even if it's severe, and I stop. I can't measure esophageal pressure in this patient.
But of course, when you have some problem in the esophagus, no, or a patient with a very high risk of bleeding, let's say that if the esophageal pressure, but is a topic of the part 2, let's say, anyway, we can anticipate if your aim is to set PEEP according to esophageal pressure. I think that this is not at all indicated in patient that seems not to be recruitable. So okay. This is a sort of contraindication.
I think we stop here. Is a good introduction to the next webinar, which will be more on the use of the measures. Thank you very much, Francesco, and thank you, Caroline.
Thank you all.
So that's it for today, everybody. There are some unanswered questions. Excuse me, there are a fly in my head. But we will provide written answers to those on the website in the next few days. We hope you enjoyed it and you found the information valuable. Don't forget to watch your inbox for the email with the link to the recording in the next few days. And if you haven't signed up for the next webinar in this series, which is next Thursday, June 23rd, you can do so using the QR code that will be placed on the screen very soon. So a big thank you to all of you for participating. A huge thank you to both our experts, and we look forward to seeing you again very soon. Thanks a lot and bye for now.